The following podcast is part of a certified educational activity titled Potential Clinical Implications of the Latest Data on Approved and Emerging Therapies for Psoriasis, a recap from Washington, D.C. Access the entire activity and complete the post-test at peerview.com/YDK860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Kenneth Gordon from the Medical College of Wisconsin in Milwaukee, Wisconsin. Welcome to this educational activity on psoriasis, focusing on updates from the 2019 American Academy of Dermatology annual meeting. In general, the efficacy and safety of therapies for psoriasis are understood through the study of randomized placebo-controlled trials. Unfortunately, these trials are limited in their scope. They have limited time, as well as having selection criteria for patients who enter, which make it not necessarily representative for the population in general. So with the new development of registries for clinical research in psoriasis, we can get a better understanding of how these medications work in the real world. One of these registries is the Corona Registry, that is a joint activity between the Corona Registry and the National Psoriasis Foundation. It's prospective and has multiple centers that are studying within this registry, about 200 North American sites to begin with. One of the elements that is studied in the Corona Registry is work productivity along with quality of life. Both of these are extremely important to our patients with psoriasis. In this study, 6 months of follow-up of patients who were treated with Ixekizumab were looked at with regards to the WPAI to measure work productivity and the Dermatology Life Quality Index to measure quality of life. In both of these elements, treatment with Ixekizumab showed significant improvement of both quality of life and work productivity. Importantly, I think it's extremely significant that both quality of life and work productivity improves with treatment. Oftentimes, we don't ask patients how their disease is impacting their work and day-to-day lives, and that's really what's driving what is important to patients in the treatment of psoriasis. In this study, the Corona Registry was used to look at the real-world efficacy of Secukinumab, and with the thought of being able to compare it to the clinical trials of this medication. In this trial, a number of parameters were looked at using the Corona Registry, including body surface area as a surrogate for efficacy, and itch and pain as symptoms that impact quality of life. In fact, in this trial, using the Corona Registry, it seemed that Secukinumab behaved pretty much as it does in the clinical trials, suggesting that we really can translate clinical trials information into the real world. The next study is an extension of the Ixekizumab study, which was a groundbreaking trial of the use of Ixekizumab for the treatment of genital psoriasis. Genital psoriasis is an area that is frequently underestimated from the physician standpoint, but has a major impact on patient quality of life. In the earlier trials, in the short term, it was identified that Ixekizumab was quite effective for the treatment of genital psoriasis and improved the patient's quality of life quite significantly. In this trial, what was done was an extension of that clinical trial data, looking at up to a year's worth of data in these patients. And what we see is the effect of Ixekizumab on not only the clinical traits of genital psoriasis, but the impact on quality of life persists for the full year. This is critically important as we begin to understand the impact of genital psoriasis on our patients, as well as what we can do to try to treat these people who suffer. The next study was the 4-year follow-up extension of the UNCOVER-3 trial, one of the phase 3 pivotal trials of Ixekizumab for the treatment of moderate to severe psoriasis. One of the questions we all face when we're treating with patients with moderate to severe psoriasis is how long our therapies will work. Because as psoriasis is a lifelong disease, we want to make sure that we can control patients and keep them that way to improve their lives. In this study, we looked at the 4 years of treatment with Ixekizumab. And while there was some small drop-off in response, it was clearly found that patients maintained response quite significantly when treated with Ixekizumab. Ixekizumab, as we know, is a very highly effective medication, and being able to maintain that response allows patients to not only get better, but stay better and have improvement in their lives from their psoriasis. The next trial is the OPTIMISE trial, and this is probably one of the most important studies that was presented at the American Academy of Dermatology. One of the questions that we all have when treating with patients with psoriasis is, if a patient is doing extremely well, can we decrease the amount of drug that we use for the patient? Alternatively, if the patient is not doing quite well enough for themselves or for the physician, can we increase the dose and get better responses? This trial, the OPTIMISE trial, looked at Secukinumab with those questions in mind. All patients were treated for 24 weeks with Secukinumab. If their response was a PASI response greater than 90% improvement, those patients were randomized into two different groups. One maintaining the normal dosing of Secukinumab, which is 300 milligrams every 4 weeks, and the other group was allowed to extend their dosing interval to 300 milligrams every 6 weeks. If the patients had a suboptimal response, and that was defined as a PASI 75 to a PASI 90, the patients were randomized either to maintain the regular dose of Secukinumab or increase the frequency of Secukinumab to 300 milligrams every 2 weeks. In other words, this study looked at people with excellent responses to see if we could extend the dosing interval, and people with suboptimal responses to look if we could improve their lot by shortening the interval. The data from this trial is very interesting and I believe very open to interpretation. So looking first at that group of high responders and looking at the patients who are PASI 90 responders and then were able to either maintain the dose of Secukinumab or decrease the frequency to every 6 weeks instead of the every 4 weeks, we see that the patients who maintain on every 4 weeks, as the package insert suggests, maintain their response at about a 10% higher rate than the patients who extended to Q6 weeks. This slide, I think, is even more telling. What you can see is that in the patients who went to the 6-week dosing interval, that not only the patients who were the PASI 90 responders, but the people who were suboptimal responders, PASI 75 to 90, or even less than PASI 75 responders, all had a poor response. You're moving the entire population to a poor response, not only those patients with a PASI 90 high-level response. I think that's extremely important to think about when thinking about not only the categorical variable of the PASI 90, but the entire population and the importance of maintaining, I believe, the Q4 week response. Looking at the other side of this study, those patients who had what was defined as a suboptimal response, less than a PASI 90, and those patients were randomized to either increasing to a Q2 week dosing interval or maintaining at the Q4 week dosing interval, it's seen that the patients who increased to the more frequent interval did gain the PASI 90 response at about a 10% higher rate than the patients who maintained at the Q4 week interval. However, this I think brings up a very, very important point. First of all, is it worth it to try to get 10% more patients by increasing patients with suboptimal responses up to the Q week dosing interval? More importantly, I believe, is that that suboptimal response is really a generic assumption of what patients want, that is a PASI 90. It is important when thinking about increasing intervals or increasing the dose that it's the patient who makes that decision. Because if a patient would be, say, PASI 75 or PASI 80 and be completely improved in terms of their quality of life, it clearly wouldn't be important to increase the dose because you wouldn't be gaining anything further in improving the lot of the patient. The final part of this study was looking at the pharmacokinetics of Secukinumab to see how much of a role that played in the results of the OPTIMISE trial. In fact, in heavier patients where one might think it might have greater impact, there probably wasn't a very significant impact of increasing the dosing interval and increasing the circulating Secukinumab in treatment of those patients. Yet, in the lighter patients, the difference in the pharmacokinetics was greater, and it did have a significant impact on patient outcomes. Thus, it might be important to be able to predict what patients might actually have improvement with the increase in dose. And that might be actually the lighter patients as opposed to the heavier patients that we thought might be improved the most in this study. So in conclusion of the OPTIMISE trial, which I believe is a very, very critical trial, the Q4 week dosing seemed to hold up in most of the patients. There were slight differences with increasing the patients who had suboptimal responses and some loss of response in the patients who had great responses to begin with, but were then decreased in the frequency of their dosing. So, in the end, it seems like most patients will do fine with maintaining the Q4 week dosing. And whether we need to change really depends on a discussion with the patient about whether they believe their results warrant changes in their dosing. At the American Academy of Dermatology this year, a number of studies looked at subgroup analyses of the primary clinical trials to see if we could find specific groups that might have better or worse responses to standard therapy for psoriasis. This study looks at Secukinumab from the phase 3 trials, the FIXTURE and CLEAR trials, to begin to understand whether there were any groups who had reduction in response to Secukinumab. In fact, there were a couple things that suggested that there were certain characteristics which predicted poor response. They included baseline body weight, heavier patients didn't do as well, failure of prior biologic therapies, and plasma drug levels. Subgroup analyses were also performed with the VOYAGE 1 and VOYAGE 2 trials with Guselkumab. Again, univariate analysis showed that most patients responded quite well to Guselkumab and was not changed significantly by things like weight. One of the things I think is very important in subgroup analyses is that oftentimes we're dealing with univariate analysis. We look at weight, look at loss of response of other medications. Rather than that, however, I think it's important to do multivariate regression analysis. By that I mean looking at all the factors together. So when you look at a patient who comes into the office, they frequently don't have just elevated weight or just having failed other medications. They in fact have multiple of those factors. And those factors probably add up to giving patients responses that aren't as what we would want to see. Importantly, I think looking at patients as a total and all their different predictive elements of their characteristics, their pre-treatment characteristics, is important in order to give the patient a good sense of what their likelihood of response may be. The next study was the CLARITY study. CLARITY is a randomized placebo-controlled trial of Secukinumab versus Ustekinumab in the treatment of psoriasis. This is the second trial that's designed almost identical to the CLEAR study, and we oftentimes do two identical studies so we can get a labeled indication that Secukinumab is superior, for example, in this case, to Ustekinumab. And like the CLEAR study before, the CLARITY study showed superiority in the short term, that is 16 weeks of therapy, between the use of Secukinumab and Ustekinumab. This difference in result happened quite quickly, within a month of therapy, and persisted through the length of the study. One of the most important things to identify is whether the use of high responsive medications for psoriasis improves patients' comorbid disease. As we all know, psoriasis, especially in severe cases, is associated with an increased risk of myocardial infarction and other cardiovascular diseases. One of the ways to look at this is to look at FDG PET analysis that's been used by investigators like Joel Gelfand at the University of Pennsylvania. What FDG PET is a measure of vascular inflammation, which has been correlated to the risk of developing a myocardial infarction. However, previous trials with this technology have shown that with adalimumab and now with Secukinumab in the VIPS trial that was presented at the American Academy of Dermatology, there doesn't seem to be an impact on the FDG PET analysis that would predict changes in myocardial infarction. Now that goes against some of the epidemiology that we've seen that anti-TNF therapies, including adalimumab, might protect patients from developing myocardial infarctions in patients who respond. So the question becomes, if these studies don't necessarily go along with what we see in the epidemiology, is it a function of our inability to measure with the Secukinumab study or the adalimumab study using this technology? Or does the technology not truly predict the risk of our patients with psoriasis for myocardial infarction? One of these trials, that with Ustekinumab, showed a slight improvement in the FDG PET analysis. However, that was mainly related not to improvement in the analysis for the patients treated with Ustekinumab, but significant worsening in the patients treated with placebo. Thus, to date, the FDG PET analysis looking at responses to therapy have not been helpful in our understanding of how psoriasis patients might improve through therapy for their disease. Another one of the medications which had significant data presented at the American Academy of Dermatology this meeting was Tildrakizumab. Tildrakizumab was studied in two phase 3 trials, the reSURFACE 1 and reSURFACE 2 studies. And at the Academy this year, these studies were combined to give more power to understand both the efficacy in terms of absolute outcomes and quality of life, as well as, importantly, the safety of this medication over time. The data showed that the quality of life and efficacy data continued to be at a very high level over the full 64 weeks that was studied. And most importantly, the safety when these studies were combined, giving greater power to the study, showed that there were very few adverse events and no new signals were understood in these trials, suggesting that the safety data with this anti-IL-23 blocker has significant power to maintain a good safety profile in longer-term use. Brodalumab is another anti-IL-17 medication that works a slightly different way than Secukinumab and Ixekizumab. It blocks the IL-17 receptor, blocking both then IL-17A and IL-17F. The American Academy of Dermatology this year, it was looked at skin clearance and patient-reported outcomes from a compiled group of the 3 phase 3 trials, the Imagine 1, 2, and 3 trials. What was identified was looking at different ways of measuring the outcomes. The trials actually had very, very similar results, and the Brodalumab at the FDA-approved dose showed very high levels of improvement that persisted over time, suggesting that Brodalumab maintains its response for extended periods of time and has a good safety record. Another one of our relatively newly approved medications for psoriasis is Tildrakizumab, a medication that blocks TNF-alpha. Tildrakizumab is distinct from other agents that block TNF-alpha as instead of having an Fc portion of the molecule, it's pegylated, making it smaller and losing some of the elements that the Fc portion would do, for example, transport across the placenta in a pregnant woman. Tildrakizumab was approved for psoriasis at a higher dose than is used in rheumatoid arthritis, psoriatic arthritis, or Crohn's disease, for which it was previously approved. In the PASI trials, it was looked at what happens with the long-term treatment. The patients who started on 400 milligrams all stepped down in their dosing after a year of treatment. So the question is, what happened to these patients after they stepped down in dosing? In fact, what was clear is that the patients who were stepped down to 200 milligrams actually lost effect at a higher rate than those patients at 200 milligrams, suggesting very, very strongly that patients who are on 400 milligrams and were gaining extra response should be maintained on that dose versus step down. The data on Tildrakizumab also suggests that for the long term, patients who have good responses should maintain at the dose they were given originally. So, in this poster, what we looked at was patients who had a PASI 75 response, so this is entirely a responder analysis, and looked at what happened as those patients went forward starting at week 48. If you recall, the patients in this trial all had to step down their dose if they were on the 400 milligram dose. The patients on the 200 milligram dose who were doing well at the lower dose to begin with actually maintained their response quite well. But there was a little more fall off in the patients who went from 400 milligrams down to 200 milligrams. And this was evident both in the PASI 75 response, the PASI 90 response, and very, very importantly in terms of the quality of life response, measured by the Derm Life Quality Index of 0 or 1, which tells us that the patient's having no impact of the disease on their quality of life. No new safety signals were identified going out to 2 years of therapy. However, I think this emphasizes once again, many patients will benefit from the 400 milligram every other week dosing, and that patients probably should be maintained on the higher dose when they are responding to Tildrakizumab. The newest medication that's been approved for the treatment of moderate to severe psoriasis is Risankizumab, a molecule that blocks the P19 element of IL-23. The Ultima 1 and Ultima 2 trials were trials comparing Risankizumab to Ustekinumab and looking at long-term responses. The short-term response and the initial responses of the Ultima 1 and Ultima 2 trials were published recently in The Lancet. However, the data that was compiled between the two trials and a unified database on safety was shown at the American Academy of Dermatology meeting. In terms of efficacy, it's clear that Risankizumab maintained efficacy at a higher level than Ustekinumab throughout the clinical trials. And this was significant from pretty much all levels of therapy and all analyses. I think one thing that's really important to point out is that if you look at the PASI 90 response or the PGA of 0-1, you can clearly see what we call sawtoothing. At the end of the dosing period with Ustekinumab, patients begin to have a little bit of return of disease. And while it doesn't seem to be very much, and these patients will oftentimes recover, it is a dissatisfier for patients being treated with Ustekinumab. At the same dosing schedule, at week 0, 4, and then every 12 weeks thereafter, Risankizumab doesn't seem to have that sawtoothing, suggesting a much smoother course of efficacy for patients treated with Risankizumab. In the integrated analysis, moreover, there didn't seem to be any new safety signals. The next study was looking at one of the other phase 3 trials of Risankizumab, looking at the adalimumab comparator and looking at the patients who were treated with adalimumab who did not have an optimal response, that is, patients who had a PASI 50 to PASI less than 90 response, and looking at what happened if they were randomized to either continue adalimumab therapy or change to Risankizumab. In fact, in this trial, it was quite clear that the patients treated with Risankizumab did quite a bit better than the patients who were treated with adalimumab in terms of gaining that PASI 90 response. Critically, I think what this tells us is that the likelihood of patients to keep on having improvement after a 16-week period on adalimumab or most other medications is relatively low. It's probably worthwhile to say after 16 weeks, it's time to switch to a drug that's more efficacious if the patient is not satisfied with their outcomes with adalimumab therapy. And I think this is one of the really important messages that we can take to our patients, that if we start a therapy, be it adalimumab, methotrexate, or any other medicine that we use for psoriasis, if the patients are not having optimal responses that is satisfactory to the patient at a relatively early time, at 3 or 4 months, it probably isn't worthwhile to keep on going, but it's important at that point to change the therapy to something that will be more effective for that patient. The next study looked at Risankizumab in terms of subgroup analyses and looking at comparing Risankizumab to Ustekinumab in the groups that tend to have lower response rates in patients with psoriasis. For example, prior biologic exposure and prior biologic failure is a very important indicator for response. And when you look at Risankizumab, you can see that in particular looking at the biologic therapy group and looking at the PASI 90 group, you see a fall off in the response with patients who have failed 2 or more biologic therapies. But the fall off is even more significant in the Ustekinumab group, suggesting that the things that indicate poor responses, like prior biologic failure, are probably the same for almost all of our biologic therapies, and that the drugs with a higher level of efficacy tend to do better in those groups. Finally, looking at the integrated data set of Risankizumab, it's important to look at safety. In looking at any high efficacy drug, we want to make sure that we're not having any new indicators of safety issues in patients with psoriasis. And when looking at the clinical trials from the pooled data set of Risankizumab, you see really no new messages being uncovered. In terms of cancer, there was no real difference between any of the groups between Risankizumab, Ustekinumab, adalimumab, and importantly, placebo in both non-melanoma skin cancer and other tumors that are excluding non-melanoma skin cancer. And I think it's critical to understand that these medications that have high-level responses do not in the clinical trials seem to suggest that there's going to be higher levels of safety messages in patients using these medications. Along with malignancy, it's important to look at other adverse events of special interest in treatment of psoriasis patients with biologic therapy. These include things like serious infections, which is probably the most important side effect we think about with biologic therapy, major adverse cardiac events, depression, suicidal ideation behavior, and hypersensitivity reactions. And in the cumulative data set with Risankizumab, you see no new signals and comparability between Risankizumab and other medications that have worked traditionally for psoriasis, including Ustekinumab and adalimumab. In fact, these medications don't differ significantly from placebo, thus suggesting that in the clinical trials at least, to be studied better in the Corrona and other databases going forward, there doesn't seem to be any significant safety risk that we see that is different from other medications and placebo in the treatment of moderate to severe psoriasis. At the American Academy of Dermatology, there were also a number of presentations that looked at future therapies for psoriasis that are quite exciting. One of these is the TYK2 inhibitor BMS 986165, henceforth to be referred to as the TYK2 inhibitor. That is an important oral molecule that might be able to improve psoriasis. TYK2 is an important signal transduction molecule that blocks both interleukin-23 production and has a major impact on type 1 interferons, interferon alpha and beta. And these are both very important in the pathophysiology of psoriasis. So the question is, not only can the TYK2 inhibitor improve the outcomes in psoriasis, but can it have an impact in the pathophysiology, in the cytokines that we expect to be elevated in patients with psoriasis? This is data from the New England Journal of Medicine article on the TYK2 inhibitor, which showed PASI 75 rates of up around 69 or 70% in the highest dosing groups. This is as high as we've seen for an oral medication for the treatment of psoriasis. So the TYK2 inhibitor, from a purely efficacy standpoint, is extremely exciting in our future ability to treat psoriasis. And these are the figures, which we'll show there. The other element that is, of course, very, very important in understanding a new medication for psoriasis is safety. And in the phase 2 trial of the TYK2 inhibitor, there didn't seem to be any new messages in terms of adverse events or infectious events in terms of treatment with this medication. However, the caveat always has to be made that this is a phase 2 trial and the numbers are not sufficient to truly judge safety. Safety is really best measured in the phase 3 large trials that are in the process right now. The next study looked at the TYK2 inhibitor and looked at the cytokines that are inhibited by the medication, because one wants to make certain that the medication is working by inhibiting those specific cytokines it's intended to do. And in this case, the IL-17 pathway driven by IL-23 and the type 1 interferons all seem to be inhibited as a way that would be predictable by the mechanism of action understood by blocking TYK2. Another medication that's in phase 3 development at this time is Mirikizumab, a molecule that blocks the P19 subunit of IL-23. At this meeting, the phase 2 data was analyzed for looking at what happens to patients when the doses of Mirikizumab are changed in patients who had suboptimal responses. In looking both at symptoms and clinical outcomes, it was clear that some patients benefited from going up to a higher dose of Mirikizumab, and that could explain for long-term how we can get patients using this medication to higher level responses and better quality of life. In conclusion, the American Academy of Dermatology this year was very exciting as a significant amount of new data was presented that has a major impact on our understanding of psoriasis and how we treat patients. I think the critical things to think about are how can we think about psoriasis in the real world, and how can we use registry data like the Corona Registry to better understand our patients as we see them in the office and not necessarily clinical trials. Additionally, trials like the OPTIMISE trial and the Tildrakizumab trials really suggest that we have to think about the patient in front of us and figuring out what's the optimal dose of medication for that patient rather than a population base, which is what's studied in the clinical trials. And finally, the newly approved and emerging therapies for psoriasis are extremely exciting. Medications like the TYK2 inhibitor, which is an effective oral medication for psoriasis, and new biologics like Mirikizumab, in addition to things like Tildrakizumab and Risankizumab, which have just recently been approved, give great promise that we can continue to improve how we treat our patients with psoriasis to improve their quality of life. That ends the discussion for today. I hope you found the activity informative and useful for your practice, and encourage you to access the practice aids and other materials that are available for download. Thank you very much for participating.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/YDK860. This activity is supported by independent educational grants from AbbVie and Novartis Pharmaceuticals Corporation. This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education.